Today we'll be discussing about one of the most critical part of neurocritical care, which is status epilepticus, a problem which is many times taken lightly or not treated properly, given less importance as compared to stroke or acute myocardial infarction. But as we know, as of today, if status is not taken care properly, it will lead to permanent neurological damage for the patient and in many cases, even death. So it is an emergency and it needs to be treated with utmost urgency and it has to be treated like an emergency. And anytime the diagnosis has to be always entertained when a patient comes to the emergency with unexplained or new onset seizures and is not conscious. So we'll discuss about a patient who is a 45-year-old man who is brought to the emergency with altered behavior. On evaluation, he is agitated, he is delirious, he is not following commands, he is tachycardic, and blood pressures are on the higher side. His father, who is accompanying him, said that he had a generalized tonic-clonic seizure as they were getting down from the ambulance outside emergency. And he was presumably okay before the seizure, and that he was coming to the emergency in view of fever for the last 3 days. He is a known case of epilepsy and is in treatment for the last 5 years, no history of any alcohol or substance abuse, and has been having fever up to 104 degrees Fahrenheit with a bad headache for the last 3 days. And for the last 2 days, he's also having multiple episodes of vomiting. As the nurse was trying for an IV cannulation, he throws up a seizure in the emergency with uprolling of eyeballs and tonic-clonic movements. So questions are, is this an isolated seizure episode? Is there any difference in the treatment of this seizure with the above history? Are there any clues in the history which could point to the reason for the seizures? Coming to the first question, this is not an isolated seizure episode. This patient is a case of status epilepticus, as the patient had 2 seizures, one outside the emergency, one inside the emergency, and in between he did not regain consciousness. He remained in delirious condition, in altered behavior, not following commands. So this is a classical definition of status epilepticus. And as I told you, this is a medical emergency, so we have to treat it like a medical emergency, not like an isolated seizure episode. As per the present understanding, if any seizure lasting more than 30 minutes could cause irreversible brain damage. So time is brain. In this patient, the patient had a fever and also headache and vomitings, which could indicate raised intracranial pressure and a possible meningoencephalitis. Also, due to multiple episodes of vomiting, the patient's possible drug levels could have gone down. He was an epileptic who was on multiple anti-epileptic drugs, and because of last 3-4 days of vomitings, the drug levels could have dropped, and which could have potentiated the possibility or development of status epilepticus. So there are many definitions of status epilepticus, but the present operational definition is more than 5 minutes of continuous seizures, or greater than 2 minutes, or greater than 2 discrete seizures, between which there is an incomplete recovery of consciousness. So either a continuous seizure of more than 5 minutes or 2 separate seizures without any regaining consciousness in between. The International League Against Epilepsy defined the time periods for status in 2015 as 5 minutes for generalized tonic-clonic seizures, 10 minutes for focal seizures, 10 to 15 minutes for absent seizures. And again, to reiterate, this is a medical emergency that may lead to permanent brain damage or even death. Status epilepticus could be rated in the possible 3 scenarios. It could be because of an existing exacerbation of pre-existing seizure disorder. it could be an initial manifestation of a seizure. The first time seizure disorder could present with status. Or it could be an insult other than seizure disorder, like as we discussed for meningoencephalitis, stroke, and other conditions. In patients with known epilepsy, the most common cause is a change or default in medication. Some common causes: hypoxic brain injury, acute old stroke with gliotic focus, tumors, subarachnoid hemorrhage, trauma, drugs like cocaine, theophylline, isoniazid toxicity, and common condition alcohol withdrawal. Many electrolyte abnormalities, notably hypo or hyponatremia, hypercalcemia, hepatic encephalopathy, meningitis, brain abscess, encephalitis, poisonings with sympathomimetics, or TC overdose, tricyclic antidepressant overdose. All could cause status. This was a audit done by the International League Against Epilepsy, called the STEP audit, or the Status Epilepticus audit, which collected information from 776 cases of refractory status in 50 countries. And as you can see, nearly 1/4 of the cases, there was no cause identified. It was called as a cryptogenic seizures or cryptogenic status. And the blue lines basically indicate the Asian continent, where the Europeans and the Americans are the European, the orange one, and the purple one is the Americans. So you could find that vascular causes of, that is stroke related and other vascular causes predominated in the European and American continents, while in the Asian continents, it is the more, status is more related to the meningoencephalitis, so infection related. So this is the difference between the etiology of status in the developed and the developing countries. Other than that, others like anti-seizure drug withdrawals, tumors, and all this also contribute significant. But as you can see, nearly 40 to 50% of your seizures either will fall in our country or in our Asian continent in the group of cryptogenic and neurological infections. Classification, like epilepsy status, also is classified into convulsive and non-convulsive. Convulsive again gets into classified into primary generalized or secondary generalization, myoclonic type, tonic type, clonic type, and very rarely atonic type, which is most commonly in children. What we are more concerned or more important to understand is non-convulsive type, which is many times missed and many times difficult to diagnose in the emergency or the critical care setup. It could be a typical absence in non-convulsive or atypical absence. So non-convulsive status, we'll discuss later, has to be identified and treated aggressively, even as the patient will not show any clinical evidence of seizing. Patients in status may also have fever or hypothermia, rapid heart rate, hypertension, both acidosis, both metabolic and respiratory. And the clinical pearl is not to aggressively treat acidosis, as acidosis helps seizure control. So unless acidosis is life-threatening, we'd better not correct it. It will help in our management of that status. There may be mild leukocytosis, but generally no band forms, and mild CSF pleocytosis. Looking at the approach, now that we have a patient with status, obviously any patient who comes with status is altered sensorium or multiple seizure episodes. ABCs predominate the management. However, there's something called DEFG, that is, do not ever forget the glucose. So blood glucose, capillary blood glucose has to be checked immediately when the patient comes with multiple seizures or recurrent or continuous seizures. Patient should be preferably put in the lateral decubitus position to minimize aspiration, and suction has to be done. IV access, once we get it, to get immediately sent for a VBG. ABGs are difficult to get in a patient who is actively seizing. So basic investigation like venous blood glucose, venous blood gases, glucose, electrolytes, sodium, calcium, magnesium, toxicological screen, beta HCG in females, creatine kinase, creatinine, and lactate have to be done in these patients. CT brain is not an emergency. If the patient is actively seizing, we should not first think of CT brain. If the seizures have settled, we can go for a CT brain. If the seizures continue, then subsequently we may have to go for a CT brain, but it is not the initial investigation of choice. So once the patient is documented seizing or suspected non-convulsive status, IV lorazepam is the drug of choice, and the dose is 0.1 milligram per kg can be repeated after 4 minutes. 2 doses of lorazepam. If it doesn't stop the seizures, then we have to go to the second line drugs. In patients where IV access may not be there, immediately a 10 mg midazolam intramuscular can be given. If no response to the first dose of IV benzodiazepine, that you can repeat a second dose and or start fosphenytoin, phenytoin, or valproate or levetiracetam, and prepare to intubate via rapid sequence intubation with propofol ketamine, which is the choice for intubating in such patients. For a neuroparalytic agent, rocuronium or scoline could be used. However, if the patient is actively seizing more than 20 minutes, scoline is better avoided in view of hypokalemia. Consider life-threatening situations, like treat those things which can be easily treatable, like hypoxemia by giving supplemental oxygen or intubating the patient, hypertensive encephalopathy by giving labetalol infusion or nitroprusside. Nitroprusside would be preferable as it can have a very rapid control of the blood pressure and titratable, very easily titratable drug. Patient treat severe hypothermia with cooling. Treat hypoglycemia, hyponatremia with hypertonic saline, hypomagnesemia, and hypocalcemia with IV calcium gluconate. Toxicologic screening if any suspicion of anticholinergic overdose by carbonated alkaline infusion to alkalinize the urine. If there's a possibility of isoniazid toxicity, then pyridoxine is the go-to drug. Another clinical pearl is profound metabolic acidosis may indicate isoniazid toxicity. The other classical example of active seizing is the state of eclampsia, which can develop up any time after 20 weeks of pregnancy, up to 8 weeks postpartum. So in which IV magnesium sulfate would be the ideal choice, that is up to 4 to 6 grams over 20 minutes, and then an infusion of 1 to 2 grams per hour. In patients, as I told, without established IV access, intramuscular midazolam is preferred. Diazepam per rectal can be used in small children, 0.2 to 0.5 milligram per kg with a max dose of 20 milligrams. However, the most important thing to remember is the time to administration. It is not what benzodiazepine you are selecting. It is the time and the dose which are most important. The earlier you give it, the better chance that you control the seizures. As longer the seizure persists, it becomes more refractory to treatment. So midazolam, diazepam, lorazepam, whatever you would have immediately, you can give to the patient. Do not delay in drug administration, and also give an adequate dose. Books may write 4 milligrams of lorazepam, which is actually not the correct dose if the patient's weight is 80 kg. So it's actually 0.1 milligram per kg. So underdosing and delayed dosing are two pitfalls which you have to avoid in the emergency management of seizures. So as I told, benzodiazepines fail and the patient is actively seizing, the second line medications will have to come in. And many patients can progress into a state called non-convulsive status. They may actively stop active seizing, but they may not regain consciousness. They may be actually in something called a non-convulsive status. They feel very difficult to diagnose without an EEG. So we should have some clues or keep our eyes open. If the patient is not progressively returning back to baseline consciousness within 60 minutes of stopping of clinical seizures, then a possibility of non-convulsive state should be thought of, and EEG should be done as quickly as possible. If EEG is not possible, treat the seizures or treat the unconsciousness or patient's neurological condition as a possible non-convulsive status with continuation of anti-epileptic infusions till EEG's monitoring is available. This is very important because non-convulsive status, if it also continues, it will also have a very poor neurological outcome in the long term. The second line anti-epileptic drugs are levetiracetam. The dosing would be minimum 20 to 60 milligram per kg with a max of 4.5 grams. Fosphenytoin or phenytoin, which is given at 20 milligram per kg with a max of 1.5 gram. And it is to be avoided in toxicology causes of seizures. I'll tell you later why. Valproate 20 mg per kg IV max to 3 mg per day, and is contraindicated in pregnancy. The ASCEP trial, which is basically a multi-center randomized blind comparative effective trial, compared these 3 second-line drugs with levetiracetam, fosphonated, and valproate, or the doses that I discussed. And the endpoint was an absence of clinically evident seizures and improved responsiveness at 1 hour. And all the 3 drugs showed equipotent or equivalent efficacy when it came to termination of seizures at 60 minutes. And this was basically a trial in around 384 adults and children. So clinical efficacy was well established with all the 3 drugs. So, however, phenytoin is not to be used if there is a TCA or cocaine overdose. Tricyclic antidepressant and cocaine overdose both basically act through sodium channel blocking action, which is also the action with phenytoin. So a concomitant sodium channel blocking increases the cardiovascular risk in these patients. Cardiac arrhythmias and cardiovascular collapse both can happen if phenytoin is given in patients with the TCA and cocaine overdose. And also patients who are non-epileptic and on phenytoin, they may metabolize the drug faster. So giving initial phenytoin may lead to a relapse or recurrence of the seizures as the patient will metabolize the dose very quickly. So these are 2 conditions where the first is an absolute contraindication, second is a relative contraindication. Propofol is another drug which can be used as second line, but it lacks data. IV bolus of 2 mg per kg followed by 3 to 5 mg per kg per hour infusion is the dose which is used. However, the data is lacking, but it is quite safe in any suspected toxicological case. Intubation comes in the picture if the patient is aspirating, patient is on ongoing seizing. Because of these ongoing seizures, he has become apneic. And there is no response to the first dose. The first adequate dose would mean 2 doses of benzodiazepine. He is not responding. The continues to seize, and you are planning to, or you are giving second line drugs. There's the time to intubate. As I told you, induction agents are most possibly best options are propofol or a combination of propofol plus ketamine. The idea is propofol works on by modulating the GABA pathway, which is the immunoinhibitor or the neuroinhibitor pathway, while ketamine works on the NMDA pathway, which is the acceleratory pathway. So potentiation of GABA and suppression of NMDA can be achieved by combination of propofol and ketamine, and which will give a better profile of easier intubation, because ketamine will counteract the hypotensive effects of propofol and also may terminate the seizure immediately before intubation. And this was published in a series of super refractory status. 2 series was presented by Sabharwal and Holfler in 2015 and 16. Ketamine with propofol called ketofol was effective in super status epilepticus. If intubation requires paralytic agent, scoline or roperidone can be used. However, scoline is avoided, as I told you, in more than 20 minutes of seizures because of hypokalemia. So do ABCs, give lorazepam 2 to 4 mg, but it is 0.1 mg per kg, or midazolam 10 mg IM. Seizures continue. Levetiracetam, fosphonated, valproate are the 1, 2, 3 drugs. Phenytoin is the other choice. If none of these are available, phenytoin is the go-to drug. Phenobarbital also can be given at this time. Still, seizures continue. Propofol infusion and midazolam infusion have to start. And ultimately, pentobarbital or general anesthesia comes in if the patient continues to have seizures despite all these things. Ketamine also can be started as an infusion at this time. So this is the flow chart. And this is the various mechanisms of action of various anti-epileptic drugs. You could see the benzodiazepine barbiturates all act through the potentiation of gamma aminobutyric acid. Benzodiazepine barbiturates and topiramate, while sodium channel blockage is done by phenytoin, carbamazepine, lacosamide, zonisamide. Levetiracetam has a unique modality of action. Basically, it binds to the SV2A subunit of the vesicles and prevent the release of neurotransmitter by making the vesicle more stable. Valproate works on the NMDA receptors also. So status epilepticus, which does not cease after 2 anti-seizure medications, that's usually an IV benzodiazepine followed by long-term long-acting, that is 2 doses of benzodiazepine followed by levetiracetam or phosphonate or valproate. If the patient still continues to seize, we would call it refractory status. While super refractory status is the seizures persisting or recurring after 24 hours of treatment. It continues for 24 hours or recurs after 24 hours when the drugs for infusion are reduced. While nausea is a new term called new onset refractory status epilepticus, where the patient first time presents with the status, most of the times it is found the cause is meningoencephalitis. So for the management of refractory status epilepticus, continuous EEG monitoring is mandatory to confirm the seizure cessation, to guide the anti-seizure medication to withdrawal, and to monitor for recurrence of seizures when the drugs are being withdrawn. Infusion therapy with midazolam, propofol, phenobarbital, or ketamine. Midazolam is the preferred because of other safety profile. However, any of the drugs can be chosen. Phenobarbital has a longer acting, lasting seizure control. Midazolam can be used as a bolus and followed by infusion. Bolus of 0.2 mg per kg followed by infusion of 0.1 mg per kg per hour. So 0.2 and 0.1, easy to remember. Propofol can be again bolus at a loading dose of 1 to 2 mg per kg and continued at 1.2 mg per kg per hour. Again, easy to remember, 1 to 2 and 1.2. Midazolam has a short half-life, the withdrawal seizures are high, while propofol has a chance of cardiovascular compromise, hypotension, and also higher doses, more than 3 mg per kg, given for more than 48 hours, can lead to propofol infusion syndrome with rhabdomyolysis, severe metabolic acidosis, and cardiorespiratory failure. Pentobarbital is the general anesthetic which we use, a loading dose of around 250 to 300, that's 5 mg per kg. That's followed by infusion of 1 to 2 mg per kg per hour, increasing till the seizure activity is suppressed. Again, higher doses cause hypotension. Ketamine is the drug which is the one which does not cause any hypotension and can be used in patients with blood pressure drop, which is a possibility, or the patient already is in hypotension. Loading dose of 2 mg per kg followed by infusion of 1.5 to 10 mg per kg per hour. Some immunomodulatory therapies are also used in special conditions. When the patient is continuing to having ongoing status, then a possibility of autoimmune encephalitis may be considered, in which high with glucocorticoids, high dose of steroid, that's 1 gram of salmeterol for 3 days, IVIG, plasmapheresis, second-line drugs like rituximab, cyclophosphamide can be also thought of. Some cases, the inhalation anesthetics are used like isoflurane, disflurane. However, hypotension is a common side effect. Some vagus nerve stimulations, transcranial magnetic stimulation, all are reports available, but most centers do not use it. Electrical convulsive therapy is a possibility, but it's again a difficult situation because most critical care units won't have electrical convulsive therapy as a backup. And the patient needs to be shifted to a different center, which itself would carry a significant risk. Thank you.